Nehal, have you joined with the two devices?
Uh,
I think two
Hello?
devices. One you can mute. Dr.
Yes, sir.
Onden Centron. Who is Dr. Onden Centron?
Hello, sir. Good evening, sir.
So you can, Nehal, you can share, and Onden Centron you can mute yourself. Just let me check.
Yes, sir. We go, Dr. Prashant, sir, and I will.
No, but there is a echo is coming. Echoing is done. One of you has to switch off your device. You can try share your screen first, Nehal, because you are co-host now. Starting, yeah, I have made online center also co-host. You can also try from that side, but you have to log out from one device because there is echo now. Dr. Nivedita is joined. Welcome, ma'am. Good evening, madam. Dr. Nivedita.
Good evening, sir.
Good evening, Nivedita.
Good evening,
Dr.
sir.
Nivedita.
Good evening, sir.
Any further progress?
Sir, I went there and I gave my CV. So Dr. Jana said to come after I come back from USA, sir.
Okay, you're going, Yeah.
Yes,
Fine.
sir.
All the best. Okay.
Thank you, sir.
I'll follow it up.
Yes, sir. Thank you, sir.
This is a iPad, Dr. Nehal.
The screen is so small.
Yeah, because this looks like an iPad screen actually.
Ask him to magnify it.
Dr. Nehal. Is there no slideshow for this one PPT, Dr. Nehal? Unmute yourself. Dr. Nehal.
Nehal is
Hello.
there. I'm not able to see.
No, he's there, I think, Dr. Prashant and Dr. Nehal.
Yeah. Nehal is there, yeah.
You can just check it out whether you got a PPT on slide mode, because some part is seen, some part is not seen.
Who is Dr. Oden Setran?
The new generation doctors. Are you able to make it one slide show or something like that, Dr. Nehal? Please unmute yourself. Unmute. Yes, yes. Are you able to make it into like slideshow kind of thing? Because you got time, because I I have to first start with the rickets presentation. Sir is taking that. So if you want to, like, this will not work because half the part is seen, half the part is not seen.
No, sir, we cannot make it.
This is on the iPad.
Yes, sir.
That's why it is showing like this. You can just zoom it for like for one slide. Can you zoom it like that? Because when you are zooming it out, this is only seeing the some part of the slides, not the full slide.
Is it okay, sir? Like this?
Little bit less, but still it is seeing like very minute this one.
Okay, sir.
Let us see. We'll start with the, because already 9 5 there. We'll start with the sir's presentation. Meanwhile, you can just see whether you can transfer to this any other laptop or like that and make it on the slideshow.
Okay, sir.
Normal PPT. So we'll start with the sir slides first. Okay, you can
Okay,
stop
sir.
sharing.
Okay, sir.
Okay, good evening, friends. First, we'll like welcome all, good evening all. And first, we'd like to go with the sir's presentation, which was pending last time. We tried because of some technical problem, we could not. But I'll start sharing the presentation. Sir will ask you the some questions and uh, like deliver discussion on the rickets. So I'll starting my presentation. Can you see?
Yeah, it's
Yes.
visible.
So
Okay.
just let me know to do the
You
next,
see,
then
yeah.
I'll do that.
Yeah, I'll say next and you just move forward because there
Yeah,
will be.
yes.
Okay. Friends, actually, this presentation consists of frequently asked questions in rickets, not only in the clinicals but also in the Viva. Actually, when it comes to bone disorders, you use four terms. Four terms. Four terms that are used are osteopenia, okay, osteoporosis, osteomalacia,
And
then
rickets.
rickets. Four terms are used, and everybody should be familiar what each term means. We all know what is rickets, and the definition of rickets is such that it is a disorder of growing bone. That's very important. It is a disorder of growing bone. Rickets does not occur in an adult. Second is, please go to the previous slide. Please go to the previous slide. Yeah. Second is, rickets is deficient mineralization of osteoid matrix. This deficient mineralization should be happening before the epiphyseal plate closes. The slides are jumping. Yeah, please keep it there. And this leads to soft and weak bones. That is rickets. Osteomalacia and rickets are essentially the same problems. That is, both of them are defective mineralization. But the difference between osteomalacia and rickets is that osteomalacia occurs after closure of the epiphyseal plate. That means it occurs only in adults. Okay. But basically, both the disorders have the same abnormality in the form of inability to form hydroxyapatite crystals in the osteoid, which is the precursor for normal mineralized bone. Okay. Next slide, please. Satish, next slide. Yeah. Okay. Yeah. Next slide. Yeah. What do you mean by osteopenia? Actually, whenever the bone mass or bone mineral density, BMD, which means the presence of lesser amount of bone material in a certain amount of bone, is called osteopenia. In fact, The difference between osteopenia and osteoporosis is almost similar to rickets and osteomalacia. Osteopenia is a less severe form. Osteoporosis is a more severe form. Move forward, Satish. If you see so osteopenia means that there is decrease in BMD. And the WHO, based on the BMD, has got some criteria where you call it as T-score between -1 to -2.5. Whereas if the values are less than 2.5, it is diagnostic of osteoporosis. Diagnostic of osteoporosis. Next slide. Next slide. Move forward. So osteoporosis, there is loss of bone mass and decline in bone density. Again, which leads to fragile bones and it increases the risk of fracture. That's what happens in elderly, postmenopausal women, etc. There is a diffuse reduction in bone density when the bone absorption, when compared to bone resorption, is less. Bone resorption is more than that of bone absorption. And if you do a biopsy of the bone, find that there is diminished osteoblastic or excessive osteoclastic activity. That is osteoporosis. Next slide. In fact, we were talking about some definitions of rickets and some classifications of rickets. In the earlier class, there was a question I was asking, what do you mean by refractory rickets? So, before that, let us move forward to the modern classification of rickets. Next slide. In the modern classification, rickets is broadly divided only into two groups. Fundamentally, it is either a calcipenic rickets or a phosphopenic rickets. Calcipenic rickets is much more common than phosphopenic rickets. And the commonest cause for calcipenic rickets is nothing but vitamin D deficiency or vitamin D resistance. And that it can be also due to calcium deficiency, where it can occur even in a malnourished child. And it can also be due to renal rickets. So the problem may be dietary, malabsorption, lack of exposure, liver disease, or some problem with the metabolism of the most active form of vitamin D, that is 125-hydroxyvitamin D, or it may be pure calcium deficiency, or it may be because of renal osteodystrophy. That is calcipenic rickets for you. On the other hand, phosphopenic rickets, most of them are hereditary. In contrast to calcipenic rickets, most common causes of calcipenic rickets are acquired. Most common causes of phosphopenic rickets are congenital. Renal tubular phosphate leak is the commonest cause of phosphopenic rickets. It can be isolated phosphate loss secondary to genetic mutation, or it can be Fanconi syndrome, or it can be dietary phosphate deficiency or phosphate malabsorption. It could be any of them causing phosphopenic rickets. Next slide. And we already discussed this. Please go to the next slide. Go to the next slide. Next slide, please. Yeah. The differences between phosphopenic rickets and calcipenic rickets are important. Please go to the previous slide. Previous slide, please. Yeah. These differences are very, very important. A clinician must recognize these differences. The important differences are, in calcipenic rickets, there will be myopathy with muscle weakness. Bone pain may be there. All extremities are involved. Tetany may occur. Enamel hypoplasia may be there. Dental abscess will not occur. Calcium will be low. Phosphorus will be low. Alkaline phosphorus is very grossly elevated. PTH will be very grossly elevated. Osteopenia will be there. On the other hand, in phosphopenic rickets, muscle weakness will not be there. There won't be myopathy. Bone pain is uncommon. Lower limbs are predominantly involved. Tetany doesn't occur. Enamel hypoplasia does not occur, but dental abscess will occur. Calcium might be low, phosphorus will be low, alkaline phosphorus will not be that greatly elevated. Parathormone may be normal or elevated. Osteopenia is usually absent when compared to calcipenic rickets. Next slide. Please move. And if you want to know the correct diagnostic approach to rickets, the most important diagnostic criteria is elevated alkaline phosphatase activity. Then you do an X-ray, then measure parathormone, measure the phosphorus level and calcium level. If the parathormone is high, phosphorus is normal or low, calcium is normal or low, it is likely to be calcipenic rickets. If the parathormone is normal or mildly elevated, phosphorus is low, calcium is normal, phosphogenic rickets. If PTH is normal, phosphorus is normal, calcium is normal, consider early or transient disease or some rare disorder of bone such as hypophosphatasia, okay, or bony dystrophies. Next slide. And vitamin D refractory rickets, is there a term at all? In fact, I searched and searched. This term is very rarely used in standard books of endocrinology or pediatrics. But there is one reference in Indian Journal of Pediatrics which says the term vitamin D refractory rickets may be used for patients who fail to show evidence of radiological healing and normalization of biochemistry despite adequate therapy. And most often refractory rickets is inherited. So anything which does not respond, say in a reasonable amount of time, like 4 months, 4 weeks to 3 months, you can call it as refractory rickets. Okay, next slide. And it can be divided again into hypophosphatemia rickets or vitamin D dependent rickets. Next one. And this is very important. X-linked hypophosphatemia rickets is one of the disorders which is now identified by genetic mapping. It is a problem of the FX gene where there is a role for FGF23 and new treatment is available. Next slide. Next slide. Where a drug called burosumab, a monoclonal antibody, please move forward, is available. This drug, please move forward. It is a monoclonal antibody. No, please go back. Please go back. Last slide. That's the last slide. What happened? This is used for refractory rickets, new drug. Okay. Okay. Satish, it's okay. It's okay. Last slide alone, please put it. Last slide. Last slide. It's a new development students must know. Last slide. Next slide. Yeah. See, this is a monoclonal antibody to FGF23. It is approved for treating X-linked hypophosphatemic rickets in children above 1 year. Very expensive. Conventional treatment has been oral phosphorus and high doses of calcitriol. Here you can use this drug which is available, which is approved for use above 1 year. Burosumab for X-linked hypophosphatemia rickets, which is an monoclonal antibody to FGF23. Thank you. Satish, over. You can move with today's program.
Thank you, sir. Dr. Nehal, you
Yes.
can just start presenting yourself. And thank you very much, sir, about this new development because we also didn't know about that.
Dr. Srinivasan, sir, you have any comments on the...
Sir, when rickets is being talked by you, there is nothing more for me to add. You have written so many review articles and your pundits.
So students, you can introduce yourself and then you can start. You are joined with the one device
So
only.
please read the Balasubramanian's article in Indian Pediatrics. Very excellent article.
Is it visible, sir, now?
Yeah,
The
visible.
slide.
Yes, Prashant.
Hello, sir. I'm Dr. Prashant Bhosle from Vinay Thakre Hospital.
Yeah, very well visible. Yeah.
Yeah, yes. And my name is Sir Dr. Nehal, sir.
Please go ahead.
Hello.
Please go ahead, Dr. Prashant Bhosle.
Sir, am I audible?
Yeah, very much.
Hello, sir. Myself, Dr. Prashant Bhosle. Hello.
Please go ahead. You are audible. You are from
Yeah,
which
you are audible
institution?
very well. Yeah.
From which institution?
Introduce yourself. Which year PG and this, which college you are from?
Sir, myself Dr. Prashant Bhosle. I'm doing DCH and I'm from Minatai Thakre Hospital.
So
Which
myself,
hospital?
That is a hospital in Navi Mumbai, sir. Minatai
Yes.
Thakre Hospital,
Minatai Thakre Hospital in Navi Mumbai, sir.
Okay,
Navi
please go
Mumbai.
ahead. Please go ahead.
Yes.
Okay, sir. So today's topic is neonatal cholestasis, sir. Sir, prolonged elevation of the serum conjugated bilirubin levels beyond the first 14 days of life, or the hello,
Go ahead.
or the jaundice that continues to progress or does not resolve by this age, and then the conjugated bilirubin should be determined. When the conjugated bilirubin level is more than 1.5 milligram per deciliter, or more than 20% of the total bilirubin level, then it is called as a conjugated hyperbilirubinemia. Yes, sir. There is a normal bilirubin metabolism, sir.
So normal bilirubin metabolism in which heme is broke down to bilirubin with the help of the enzyme heme oxygenase. And bilirubin is converted to bilirubin with the help of the enzyme bilirubin reductase. Then in the blood, bilirubin, that is unconjugated bilirubin, which is a lipid soluble, which is not water soluble, which is bound with the albumin to form unconjugated bilirubin, and it forms to conjugated bilirubin with the help of the enzyme glucuronic acid. The conjugated bilirubin then enters the liver, then enters this duodenum, which is converted to urobilinogen and stercobilinogen. Urobilinogen in kidney, it forms to it excretes as a urine, and in the intestine, with the help of stercobilin, it into the stools. And some 10 to 15% of the bilirubin enters against the liver. This is called as enterohepatic circulation.
So can we go to the next slide?
Yeah.
Yes, sir. So basically, sir, the neonatal cholestasis is
1 minute, 1 minute, 1 minute. Before we move further,
Yes, sir.
Yes, sir.
I want you to tell me what is the definition for neonatal cholestasis. One, fundamentally, you have to understand the definition.
Yes.
Second, what is the cutoff of bilirubin value for you to start referring to a possibility of neonatal cholestasis? Two questions I have, practical questions.
Sir, first of all, as I tell, sir, if the conjugated bilirubin is elevated for more than conjugated bilirubin is elevated is more than 1.5 milligram or per deciliter, or the
What is your reference? What is your reference for 1.5 milligram?
Oh, sir, it is more 20% of the total bilirubin level, sir.
No, if I remember correct, of course, please go and check. If I remember correct, I remember reading up to date, mentioning 1 milligram as the threshold for
Okay, sir.
cholestatic liver disease in a young infant. I remember reading up to date. Please go and check up. I will also check up later.
Yes, sir. Yes.
More than 1 milligram is considered the threshold.
Okay, sir.
And generally, the cutoff point is 14 days. 14 days. Anything which is beyond
More
14
than 14
days
days.
is a cutoff point. And even for this cutoff, there is in fact, you can, they say for babies who are receiving parental nutrition, the cutoff can be even higher, serum bilirubin, direct bilirubin of 2. Please go and check. If I remember correct, my memory, I'm sure, is right with regard to this definition of cholestasis.
Yes, sir.
Any infant who is found to be jaundice at 2 weeks and if breastfed more than 3 weeks, even if the stool and urine color are normal, you should consider the possibility of neonatal cholestasis. In fact, I am repeating some fundamental points for the sake of other postgraduates. Remember, the threshold is direct bilirubin of more than 1. The threshold timing is usually 2 weeks, which can be extended to 3 weeks if the babies are exclusively breastfed. The threshold does not depend on the color of the urine or the color of the stool. Okay. Anybody who's on parenteral nutrition, it may be the threshold may be you can wait for about 3 weeks.
Okay, sir.
Okay. And it is 2 milligram if it is parenteral nutrition. Okay. I'm sure this is given in standard books as well as in up to date, if my memory is correct. Okay.
Yes, sir.
Thank you. Go ahead.
Yes, sir. Sir, the neonatal cholestasis is divided into two classification. One is intrahepatic and the another is extrahepatic. The main thing is, sir, extrahepatic, where there is a bile duct injury or there is obstruction in the bile duct, which is known as a biliary atresia or extrahepatic biliary atresia. Then the another is the intrahepatic disease, where there is a hepatocyte injury. The hepatocyte injury, it may be caused due to metabolic disease or maybe a viral disease, or there is a idiopathic neonatal hepatitis.
Basically, just to make postgraduates understand, cholestasis, actually, the term cholestasis means there is some problem, transport problem.
Yes, sir.
Transport problem or excretion of bile. Okay.
Yes.
And this problem, which consists of an impairment in excretion of the bile, it can be caused by one, there may be a defect in the production of bile in the liver, maybe due to a primary liver problem. Second, it may be a transport problem where the bile is not transported across the membrane, where there is a transmembrane transport. Third is a mechanical obstruction. Just to give you examples, an infant who has got a primary liver disease, hepatitis, cirrhosis, that is an intrahepatic production of bile problem. The transmembrane transport may be disorders of bile acid metabolism, inherited disorders. Third one is mechanical obstruction to bile flow, which may consist of disorders like choledochal cyst. So these three mechanisms can result in neonatal cholestasis. This is very, very important for us to understand the basic mechanism, because all these three mechanisms will have different manifestations. For example, one who has a problem in the intrahepatic production of bile will have symptoms and signs related to liver disease. One who has a transmembrane transport may not have symptoms referable to the primary liver disease. One who has a mechanical obstruction will have obstructive features more than liver disease. I mean, these are all subtle differences where you can even clinically identify the pathology behind the cholestasis. I hope you understood.
Yes, sir.
Please go ahead.
So, the extrahepatic etiology, as you told, sir, there is a obstruction in the bile flow will lead to the extrahepatic biliary atresia. It includes the extrahepatic biliary atresia, choledochal cyst, bile duct stenosis, cholelithiasis, that is a bile stones, or there is an extensive compression of the bile duct. And the intrahepatic etiology consists of metabolic causes, septic or viral etiologies, and there is idiopathic neonatal hepatitis, sir. For the intrahepatic cause, the viral etiology includes maybe a hepatitis, cytomegalovirus, herpes virus, echovirus, or syphilis. And the metabolic.
1 minute. In addition to, see, you must remember, hepatitis viruses causing neonatal cholestasis is exceedingly rare. What happened to your slides? Hello? 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 What happened to your slides? Okay, hepatitis viruses causing neonatal cholestasis is very, very unusual. The most common viruses implicated are CMV and herpes. Please include any bacterial infection like urinary tract infection or E. coli sepsis. You have not mentioned there in the list. Hello?
I think he is not able to connect, I think.
Connection is lost. Satish?
Hello.
Satish, there is some problem
Sir,
with
sir, coming, sir, coming, sir. Sir, seeing one patient, he's coming in just a minute.
Anyway, until he joins, it's very important to know that most causes of neonatal cholestasis are not due to infection. That is one. Second is, the so-called idiopathic neonatal hepatitis. It is often joked. The term idiopathic refers to the doctors being idiotic and the parents' plight being pathetic. The
You to
percentage
tell that,
percentage of cases of neonatal cholestasis where you do not identify the etiology and you label as idiopathic neonatal hepatitis has been gradually coming down from about 50 to 60% 2 decades back to around even 30% in the West, and even in our own center, it's more a diagnosis of exclusion, because today we have facilities to diagnose many of those inherited disorders of bile acid metabolism, which were never thought of 20 years back. Okay, beyond biliary atresia, we always used to label any other cholestatic jaundice for which diagnosis was not obvious as idiopathic neonatal hepatitis. Today, the number of such labels is far less than what it was 2 decades back. I'm sure Professor Srinivasan would agree.
Absolutely, sir. So I expected that statement also. Idiopathic is, that you already mentioned it. Yeah.
Okay. Satish,
And what about
happened?
that two conditions, Rubin-Johnson syndrome
Dr.
and
Nehal,
Rota syndrome?
Yeah.
can you send me the PPT on the group so that I can share?
Host me again, sir. I just
Yeah.
limit it.
Just make
Dr.
you.
Bala,
Yeah.
Online session, sir,
Rubin-Johnson and Rota syndrome come in which category?
They will come and, strictly speaking, Dubin, Johnson, and Rotar will come as differential diagnosis for cholestasis, sir. Hepatocellular
But
jaundice.
is it, yeah,
congestive bilirubin.
I have make you Dr. Online syndrome. I have made you co-host. You can just try right now. You can log out from Neil's device. There was no, I think, echoing from that.
Yeah, now it is there. Now it is there. Yeah. Go ahead.
Hello, sir.
Yeah, go ahead.
Okay, thank you, sir. Hello.
Please go ahead.
You are audible. You can start, doctor.
Yes, metabolic etiology includes, sir, there is galactosemia, tyrosinemia, lysosomal acid lipase deficiency, and Zellweger syndrome. For lysosomal acid lipase deficiency, sir, it is a rare autosomal recessive lysosomal storage disorder where mutation seen in the lysosomal acid lipase gene when due to mutation in DIPA gene leads to the decreased lysosomal acid lipase activity, which resulting in the accumulation of cholesterol ester in multiple organs, which progresses to the liver failure. The next syndrome is the Zellweger syndrome, which is also known as the cerebrohepatorenal syndrome. It is a rare autosomal recessive disorder in which there is a progressive degeneration of the liver and the kidney, in which there is a severe or generalized hypotonia, or there is impaired neurological function. On the structural examination on hepatic cell, there is a absence of paroxysm.
It's a peroxisomal disorder.
Yes, sir.
So clinical presentation of neonatal hepatitis presents with a persistent jaundice which is more than 14 days. The neonate can also present with a clay colored stool or alcoholic stools, dark color urine.
Jan mentioned some syndromes, when
Yes.
cholestatic syndromes like Alagil,
Yes, sir.
Zellweger, and other things in the causation.
Yes, sir. There is already I have mentioned that there is a lysosomal acid deficiency and the Zellweger syndrome, and metabolic also include that galactosemia,
If you
tyrosinemia,
have mentioned, it's fine. Yeah, I probably missed it.
and also, sir, it also include Alagille syndrome also. And
Because by clinical features and external features, we can diagnose some of these.
Okay, one exam question. Is there
Yes.
any autoimmune disease which can cause neonatal cholestasis? PGs can put in the chat box. Autoimmune disease causing neonatal cholestasis. Anybody? Anybody can put in the chat box, please? No, not PFIC. PFIC is not a. No, it is neonatal hemochromatosis. It is an autoimmune disorder because the mother actually is responsible for the immunological phenomena, and even the mother getting treatment with the IVIG can resolve the issue. IVIG is one of the methods of treatment. You can diagnose even antenatally. It's considered an autoimmune disorder today. Neonatal hemochromatosis. It's eminently.
Nivedita has already mentioned.
Yeah. It is caused by transplacental passage of reactive immunoglobulins from the mother. It was called neonatal hemochromatosis or neonatal iron storage disease. Today, the term itself is changed. It is called gestational alloimmune liver disease. GALDI. That is a new term. Right? It can be treated with intravenous immunoglobulin to the mother antenatally and also to the baby after birth. Right? Okay. Yeah. Somebody has put correctly, GALDI. Go ahead.
Yes, sir. So whenever the patient neonatal cholestasis is present, it mostly presents with the persistent jaundice more than 14 days, clay colored stool or alcoholic stools, and dark urine, sir. And some signs and symptoms depend on the specific disease, sir. It's most commonly present with the clay colored and dark urine. Yes. Then, sir, there is a extrahepatic biliary atresia, a lack of lumen in a part of extrahepatic hepatic bile duct, which is causing the obstruction of the bile flow. It's undefined initiating insult causing the inflammation of cells or the cells within the biliary tract. This inflammation, it results in the cholangitis, which led to the progressive sclerosis, and it will lead to the narrowing of the biliary tree, and it causes the biliary atresia, and the bile flow is obstructed.
Obstruction of bile flows. So there is a difference between extrahepatic biliary atresia and a neonatal hepatitis. The first point for to differentiate is a family history in which the extrahepatic biliary atresia, the family history not means it's unlikely any neonatal hepatitis it's a positive. The stool consistency that is a clay colored shoots in extrahepatic biliary atresia, and it's a normal means pigmented stool, or it can be a clay colored stool in neonatal hepatitis. The child is not sick looking in extrahepatic biliary atresia. The child is sick looking in a neonatal hepatitis. The in science in per abdomen examination, there is an abnormal size and the consistency of a liver is more common, and in neonatal hepatitis, the consistency of liver might be a normal. And on liver biopsy, sir, the hepatic lobular architecture is intact in extrahepatic biliary atresia, and in neonatal hepatitis, there is a disturbance in the lobular architecture of the neonatal hepatitis.
Okay, any other points? Splenomegaly. Splenomegaly, if present, favors biliary atresia or hepatitis?
No, sir. If splenomegaly is present, it will not, it will not favors the biliary atresia.
Yeah, it is more in favor of neonatal hepatitis. Dysmorphism. Dysmorphism.
The dysmorphic pieces is not a, it's depends on the syndrome. If it's present with
Dysmorphism favors non-neonatal hepatitis. Neonatal hepatitis doesn't cause dysmorphism.
yes,
Only biliary atresia and other biliary bile acid disorders, Alagili, they only cause dysmorphism.
yes, sir.
Yes, sir.
Neonatal hepatitis, you don't get any dysmorphism.
Dysmorphism.
Okay? Consistency of liver, will it give any clue to biliary atresia versus neonatal hepatitis? The harder the liver, more are the chances of extrahepatic biliary atresia.
Yes.
Okay?
Yes, sir.
Weight to the child. Weight to the child. Weight to the child and failure to thrive is more common in low birth weight, and failure to thrive is more common in neonatal hepatitis or extrahepatic biliary atresia.
Yes, it's more sick-looking child is more commonly present in neonatal hepatitis.
Yeah, more failure to thrive, more is the possibility of low birth weight, or all favors of, or all factors favoring neonatal hepatitis.
Yes, sir.
Incidentally, have you heard of a term called Landing's hypothesis? Anybody? Sir, Professor Srinivasan would know more about it than me.
No, I don't know, sir.
Landing.
I haven't
Actually,
heard of it. First time I'm hearing, yeah.
actually, there was a pathologist called Landing who extensively studied the disease 5 decades back, and he hypothesized that both neonatal hepatitis and biliary atresia are diseases caused by the same etiological insult, which
I
people
know, but I didn't know it was Landing's hypothesis. Okay.
Yeah, that same. And they blamed viruses like Rio viruses, the antenatal period, where the same virus in two different individuals, in one it can produce neonatal hepatitis, in the other it can produce biliary atresia. In fact, there are reports of Landing where he did multiple biopsies in infancy, where initially the initial picture was that of neonatal hepatitis, second picture was that of biliary atresia. In fact, vanishing bile duct syndrome. That was first described by Landing. So this is called Landing's hypothesis, where both neonatal hepatitis and biliary atresia are considered as different presentations of the same disease. Okay?
Yes, sir.
Okay. Please go ahead.
Yes. Sir, for the next diagnostic workup, we do the
Clinically, what are the
Yes, sir.
various disorders which cause cholestatic jaundice can be clinically diagnosed. Other than idiopathic neonatal hepatitis and extrahepatic biliary atresia. Can you give some examples? Okay, I will give you clues. Suppose there is a cardiac murmur, dysmorphism is there, eye abnormality is there, some vertebral anomalies are there. What do you think of?
Cyanotic heart disease usually, yeah.
It can be either
Starting in
torch
A.
infection or Alagili. Torch infection or Alagili. Okay, you
Yes.
can easily
Yes.
diagnose. And any
Butterfly type of vertebra.
baby
You have heard
who's
of
got,
butterfly vertebra?
sir,
Sorry, sir.
any baby who has got cataract, what are the possibilities? Child cholestatic jaundice, cataract,
Galactosemia, sir.
galactosemia. Other than galactosemia, intrauterine infections again.
Yes, sir.
Intrauterine infections again. Other than galactosemia, any baby who vomits after breastfeeds, goes in for hypoglycemia, throws a seizure, hepatomegaly, then you think of galactosemia, isn't it?
Yes,
Like
sir.
that, you can make out a few disorders. In fact, one of the problems, however rare it is, which can go undiagnosed, is cystic fibrosis. So, history of delayed passage of meconium, meconium ileus, stool trypsinogen test being positive. Okay. So,
Yes, yes.
all these
Xerostomia is
are
another one.
screening tests for CF can pick up cystic fibrosis right in the neonatal period when there is
We had
cholesterol.
seen tyrosinemia, 2 cases with
Tyrosinemia. Okay, which can
Yes.
cause neurological problems, metabolic acidosis, etc., liver disease. I'm just giving a few examples. And more importantly, a palpable mass in the abdomen. What is your diagnosis? Neonatal cholestasis, palpable mass, choledochal cyst.
Yes, sir.
If you are lucky, you may get a cyst in the abdomen. You may be able to palpate. Right?
Yes, sir.
Go ahead. Please go ahead.
Yes, sir. Sir, after this, we'll do diagnostic workup in which we will do the basic blood investigation like complete blood count, liver function test, in we'll do the ALT, AST or total bilirubin, blood culture, urine culture, and urine for reducing substance to look out for galactosemia, and hepatic cholangiography and hepatobiliary scintigraphy.
Hepatobiliary scintigraphy, how often it is required?
Initially, ultrasonography itself is important.
Before
Okay,
that, you
choledochal
should talk about
cyst can be
ultrasound.
found out,
No.
and also the triangular sign is mentioned. Then
Yeah.
subsequently you do,
Yes, sir.
Go ahead.
Sir, on ultrasonography is one of the important diagnosis, as you told, sir, to diagnose the extrahepatic biliary
It's
atresia.
available in many centers, and so natural data has to be told initially.
Yes, sir. On ultrasonography, sir, there is a micro gallbladder or a gallbladder is not at all visualized in case of extrahepatic biliary atresia, and there is a triangular cord sign can be seen on the USG. It is basically a cone-shaped fibrotic mass which is cranial to the bifurcation of the portal veins. That is a triangular cord sign.
See, it's very important to perform an ultrasound in any child with neonatal cholestasis for the following reasons. The first and foremost reason is to rule out a choledochal cyst, which is a surgically curable cause for cholestasis. That's number one.
Yeah, correct.
Number
Absolutely.
two, you can make out non-visualized or absent gallbladder. Number three, you can make out triangular cord sign.
Yes.
When you say triangular cord sign, it means a triangular or a band-like periportal echogenic density more than 3 millimeter in thickness. That examiner can ask you, what is triangular cord sign? Is a triangular or band-like periportal echogenic density more than 3 millimeter in thickness.
Okay, sir.
In addition, ultrasound will also give you clues to situs abnormalities. There is a syndrome called IV mark syndrome, where you can get polysplenia, mesocardia, and cholestatic jaundice. It can be associated with biliary atresia, or many vascular anomalies can be associated with biliary atresia. They can all be picked up by ultrasound. That is the usefulness of ultrasound. And recently,
Shear wave elastography.
yeah,
That is
there
another
is-
thing which is being done.
yeah, correct. There is a new test called transient elastography. It is coming up in a big way, where they identify greater liver stiffness in biliary atresia when compared to those without biliary atresia. Okay. Of course,
Yes,
the
sir.
other test is MRCP, magnetic resonance imaging, cholecystopancreatography, but it is not done in most cases because you require anesthesia to perform the test. Very difficult to do it in a newborn. And it's not very reliable for making a diagnosis. But this is very, very important to do ultrasound and to know the recent test called transient elastography. It was not available in most centers in India. It's abroad, it is coming up in a big way. Please go ahead.
Yes.
Sir, we will also do liver biopsy to do activity investigation. Or
Scintigraphy is not done at all. The so-called Bilida scan, HIDA scan, Bilida scan is no more done because it's not going to be conclusive. It can be false negative or false positive. Okay, only in very doubtful cases we can do. Another disadvantage of doing scintigraphy is that for doing scintigraphy, you have to prepare the infant with 5 days of phenobarbital. And
Yes.
by the time you get the report, 1 week is wasted. Unless you operate before 2 months of age, before the completion of 2 months of age, results are not going to be good if you do a Kasai. So for these reasons, very rarely only HIDA scan or Bulida scan is done these days. Please go ahead.
So liver biopsy is the main treatment, means main diagnostic workup in which we can tell about the hepatic architecture, which is intact in the extrahepatic biliary atresia.
More than liver biopsy, I would say it's not liver biopsy is important. What can anybody put in the chat box? Which is the most important investigation even without liver biopsy? Peroperative cholangiography. That is the most important decision-making test. On the table, you do it, and that is what helps the surgeon to decide on Kasai's procedure as a life-saving measure and a liver-saving measure. Okay? It's not
Okay,
liver biopsy. Liver biopsy, of course, is done on the table, but on the table, it is peroperative cholangiography. Go ahead.
Okay, sir.
Next point is, sir, management.
Please go ahead.
Sir, on management side, so there is we do a exploratory laparotomy or direct cholangiography. In case on exploratory laparotomy, if the lesion is correctable, when there is a direct drainage can be accomplished. In case of any correctable lesion present. Other procedure we can perform, that is, sir, Kasai's procedure. Kasai procedure, it is also known as hepatoportoenterostomy. There are some factors which are in favor of the Kasai procedure. If the patient's age is less than 60 days, and the presence of free bile flow following the portoenterostomy, if the size of duct is more than 150 micron, and the success of operation is much higher if it's performed before the 8 weeks. So can we go to the next slide?
Yeah, please go.
Sir, for treatment, like we have to also give the nutrition treatment like additional calories and additional proteins and supplement calories with medium chain triglycerides and essential fatty acids, because there is a defective malabsorption and malnutrition which resulted from ineffective digestion and absorption of the dietary fat. So that's why we have to give, sir, medium chain triglycerides and essential fatty acids. So for that, we will give, sir, fat soluble vitamins like vitamin A, D, E, and K. And for further treatment, like we will also do a treatment of pruritus, ursodi, which is a drug, ursodeoxycholic acid, which is a colorectal agent and which increases the bile flow, decreases the extrahepatic circulation, which decreases also serum cholesterol levels. And there is another drug which is a cholestyramine, which is a bile acid binder. So the complication of the neonatal cholecystitis can be a portal hypertension, which will lead to variceal bleeding. So for portal hypertension, we have to manage fluid resuscitation with blood products, with sclerotherapy, and means to stop the bleeding, we have to also do the balloon tamponade.
So can we move to the next slide?
Yeah, please go. Please go.
Yes. So the ultimate treatment for the liver neonatal cholecystitis is the liver transplantation. It is for the patients who are in the advanced liver disease. In hepatic transplantation, the success rate is more than 90%, and actually, the success rate depends on the intra, pre-operative, and the post-operative care. The prognosis of the neonatal cholecystitis, among all of the 60 to 70% of the neonatal cholecystitis cases recovers with the no evidence or the structural and functional impairment. After which, the 5 to 10% of the patients have a persistent fibrosis and the inflammation, and there is small percentage of very advanced and severe liver disease such as cirrhosis required a liver transplantation.
Okay. Okay.
Yes, sir.
Anything else?
Yes, sir. Yeah. Okay, sir.
Is that all? Is that all?
Yes, sir. The neonatal cholecystitis ends here, sir.
Okay.
The next
Okay.
topic is
Sir,
the liver.
Professor Srinivas, and your comments before we move to the next topic. It's already
Yeah, there is,
9:55.
of course, most of the things covered. Of course, it's important that it has to be diagnosed, and it is that, of course, medical legal problem if the diagnosis missed before making, So it's very essential that diagnosis is made early and then appropriate management is done.
Dr. Thapa is known to be very fond of using the term yellow alert. Okay. Many a time, these babies are diagnosed to have physiological jaundice and given leave 52 drops or not given proper advice. You have to look at the stool and you have to look at the urine and the diaper color. Okay. Make an
Yes.
early diagnosis. Now the survival is improved.
And of course,
very much
stool
after-
chart is very important.
Yeah. Okay. 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 Thank
Yes,
you. Well done.
Very, Doctor, stool chart is very much, especially in
Yes,
China
stool
and
chart.
Taiwan,
Yes,
Yes,
sir.
sir.
very commonly used.
Okay. Well done. Well done. Well done. Yeah.
Yes.
We'll move to the next topic. Who's doing it?
Yes, sir. We have another topic, sir. We are doing it.
We are
Yeah,
only doing.
please. Yeah. Go ahead.
Yes, sir.
Can I start, sir?
Yeah, please. Who's doing it?
We both are doing, sir. Dr.
Okay, go ahead. Go ahead.
So there is a live vaccines. Sir, we will start first with the introduction, like definition of vaccination. Definition of vaccination is like act of introducing a vaccine into a body to stimulate the immune system to protect against an infection. Continue, sir.
Go ahead. Please go ahead.
Yes. So there are two types of immunity. One, first of all, is the innate immunity system, and there is a adaptive immune system. Sir, I am mentioning the difference between the two immune system. The first is, sir, about the response. The innate immune system shows rapid response, response within hours, and the adaptive immune system shows the response which is delayed. It may take days also. The next up is about the specificity. The innate immune system shows a non-specific response, while the adaptive immune system shows it's a highly specific response to the antigen. And the next is, sir, there is no immunological memory in case of innate immune system, and there is a immunological memory is present in case of adaptive immune systems. Can you move to the next slide?
It's very similar to the differences between border security force and the army.
Yes,
Okay.
sir.
Innate system is like BSF. It is
Yes.
just a preliminary response. Okay. It's
Yes,
not
sir.
very highly sophisticated. Whereas your adaptive system is very, very specific. Okay. Good immunological memory is there. It's similar to an army's response, which is very specific to a particular type of enemy. Okay.
Yes,
Okay,
sir.
sir. So, types of vaccine like live attenuated vaccines. In live attenuated vaccine, we have BCG, OPV, MMR, varicella, rotavirus, and live influenza and live hepatitis A vaccine. Inactivated vaccines are whole cell inactivated, in which we have whole cell pertussis vaccine, rabies, IPV, and hepatitis A. Toxoids like tetanus and diphtheria. Protein vaccines are cellular pertussis, polysaccharide vaccines like typhoid, pneumococcal, meningococcal, polysaccharide vaccines, and conjugated polysaccharide vaccines like pneumococcal vaccine, meningococcal conjugated vaccine, and typhoid conjugated vaccine.
1 minute, 1 minute. Which vaccine is missing in the live? Go ahead, go up. Can any PG tell me there is one vaccine which is missing in the list of live vaccine, which is being used routinely also? Hepatitis A is also available as a live viral vaccine.
Yes, sir. Live hepatitis A.
Okay, hepatitis A has got 2 types of vaccines available throughout the world. The Chinese is the live vaccine, which is also available in India. Okay, the other one is your Habrix hepatitis A, the DNA vaccine. So you should include hepatitis A live as a live attenuated vaccine as one of the live attenuated vaccines. Okay.
Okay, sir.
Okay. And olden days we used to have typhoid, oral typhoid vaccine, which is not available now. Okay.
Okay.
And similarly, JAB-B, Japanese encephalitis vaccine, one of the vaccines is a live viral vaccine, though it is not being used routinely. Okay, only attenuated vaccines or inactivated vaccines are used nowadays, but live viral vaccines were available until recently.
Yes.
Okay? Go
Yes,
ahead.
sir. Sir, my next vaccine is the BCG vaccine. BCG vaccine is a live attenuated vaccine, which is made from the Mycobacterium bovis. Is used to prevent the tuberculosis and other mycobacterial infection. Next.
What up?
So one slide is missing, sir. 1 minute, sir. PPT open करना, submit.
Just 1 minute, sir.
offline मध्ये केलेलं नाही, sir.
Doesn't matter. Go ahead.
Okay, sir. Actually, there is slide missing. One slide missing, sir.
What
Sorry
did it contain?
Sir, it is about the BCG.
vaccine.
I'm telling it, sir. I got it.
Yeah, please tell. Doesn't matter. Without the slides, you tell what you wanted to convey.
Sir, the dose of the BCG vaccine is 0.05 ml, which is given intradermally on the lateral aspect of the left forearm. Is given at a bird.
If given in an older child, what is the dose?
0.1 ml, sir.
0.1 ml.
Yeah, you can give up to 5 years. Okay.
Yes. Yes, sir. Yes.
Right. Beyond neonatal period, you can give 0.1 ml.
Yes, sir.
1
Yes.
ml. It's a freeze-dried vaccine. Diluent is normal saline. It has to be used within 6 hours of preparation of the solution.
Yes,
right?
sir.
Use an insulin syringe to
Yes, sir.
give that. Okay.
Yes,
Yes,
sir.
Go ahead.
It is, as you told, sir, it is diluted with the diluent or the sterile NS. The storage temperature of the BCG vaccine is 2 to 8 degrees Celsius. and it is protected from the light, sir. After the BCG vaccination given, there is a reaction. For the next 2 to 3 weeks, there is a papule formation. For next another 5 to 6 weeks, there is a 4 to 8 millimeter papule formation. And at the 6 to 12 weeks of age, there is a scar formation at the site of injections.
If no scar develops, what do you do?
We don't repeat vaccines, sir.
There is no need to repeat. It may
Vaccine.
still have immunity. And
Yes, sir.
as per the ACAP guidelines, it is recommended only up to 5 years of age.
Yes,
Right?
sir.
Good.
Yes. The next point is about the efficacy, sir. The efficacy of the BCG vaccine in case of pulmonary TB is 59%. In case of TB meningitis, it is about 73%. And in case of miliary tuberculosis, it is 77%, sir.
Do you give BCG to low birth weight and preterm infants? Yes or no? Preterm and low birth weight, do you give BCG? Yes or no? Can anybody put in the chat box?
Yes, sir.
Correct. The correct answer is yes. As soon as the
Yes.
baby is fit for discharge and medically stable,
Yes, sir.
okay, or medically stable, you can give. No harm. Okay?
Yes, sir.
Yes, sir.
Okay.
One of
Go
the adverse reaction of the BCG vaccination is the, sir, BCG adenitis, which
Hmm.
causes due to the wrong techniques.
Hmm.
Yes. Thank you.
Under yes, sir. So next vaccine is a oral polio vaccine, which is also live vaccine. The last case of polio was reported in the year 2011, and India was declared polio free by the year 2014. It's available in the three forms, sir. That is a trivalent vaccine, bivalent vaccine, and a monovalent vaccine. Trivalent trivalent oral polio vaccine was used till April 2016, and it was switched over to bivalent oral polio vaccine in a year which occurred in April 2016. Sir, continue in the next slide, sir.
Go ahead.
Yes, sir. Sir, the dose of the oral polio vaccine is a 2 drops, that is 0.1 ml, which is administered orally, and the schedule is at birth, 6 weeks, 10 weeks, and 14 weeks, and the booster is in the 16 months and the 24 months. The storage for oral polio vaccine 2 to 8 degrees Celsius. The adverse events can be vaccine associated paralytic poliomyelitis or vaccine derived poliovirus.
Go ahead.
Yes, sir.
Go ahead.
Yes.
Sir, the next vaccine is the rotaviral vaccine, sir. Rotavirus is the globally the leading cause of the severe dehydrating diarrhea in children aged less than 5 years. The rotavirus is given, vaccine is given orally, and it can be given up to the 1 year of age. And the storage temperature is the 2 to 8 degrees Celsius, sir.
You mean to say it can be given, even the first dose can be given at 1 year?
Can be given.
Can be given up to 1 year of age, sir.
No. What is the upper age limit for giving the first dose?
1 year, sir.
1 year. Actually, WHO has allowed it up to 1 year. But I think beyond 14 weeks, the first dose should not be given. And up to 1 year, the catch-up dose can be given. The manufacturer's recommendation is only 8 months. But the government allows up to 1 year. WHO allows up to 1 year. Go ahead.
Yes.
What do you do if the baby spits the rotavirus vaccine?
We don't repeat it, sir.
Correct.
Yes, sir.
Why you don't repeat it?
Sir,
Because of risk of interception, though Indian studies have clearly shown that our Indian vaccine does not have increased risk of interception. Go ahead.
Sir, there are 4 preparation in the rotavirus vaccine, sir. First is RV1, second is RV5, third is Rotavac, that is 116C, and the fourth is Rotasil, that is 13 RVPV, sir.
Hey, your efficacy data is incorrect. Rotavac as well as Rotasil has got enough data to say it is as effective as Rotarix or Rotatec. Go ahead.
Okay, sir.
Sir, next vaccine is a measles vaccine. In which the dose is given is 0.5 ml subcutaneous in the right upper arm, which is given subcutaneous route. The schedule for the measles is the first dose can be given in the age of 9 to 12 months, and the second can be given at the age of 15 to 20.
What is the
24.
earliest age you can give measles vaccine?
It's
Youngest
9,
age?
6 months.
6 months. 6 months. Correct. 6 months. Correct. Go ahead.
And it's a storage, sir. It can be stored between the 2 to 8 degrees Celsius, and the local reaction can be local pain and tenderness at the injection site, and in some cases there can be a fever, and rash can be also be in the 2% of the cases. The contraindication for measles vaccine is, sir, it is not given in the pregnancy, and in the immunosuppressive states, and in the severe immunocompressive states.
Can you move to the
Standalone measles vaccine is nowhere available in the world. Only MR or MMR is available. Go ahead.
Yes. So the next vaccine is varicella, sir. It is a highly contagious virus which causes both varicella, that is chickenpox during the childhood age, and the herpes zoster, that is shingles in adult life. There are three type of vaccine, varicella vaccine are available in India. That is Variped, Varilrix, and there is Nexipox. So dose of varicella vaccine is 0.5 ml given subcutaneously. The earliest it can be given at the age of 15 months, and the second dose can be given at the 3 to 6 months apart. The children below 13 years, 2 doses of the varicella vaccine can be given between the 3 months apart, and the children more than 30 years, 2 doses can be given 4 to 8 weeks apart. It can be stored in the 2 to 8 degrees Celsius temperature, sir. And the contraindication for the varicella vaccine are the pregnancy, immunocompromised states such as HIV, and if the patient is on the immunosuppressive drugs.
Go ahead.
Yes. The final slide, sir.
Okay. What about hepatitis A vaccine? What is the difference between live attenuated vaccine and inactivated vaccine? Hello, you stop sharing.
Yes, sir.
Stop
Yes.
sharing the slides. Yeah. What are the differences between the live attenuated hepatitis A vaccine and inactivated vaccine? The difference is in the schedule. Only one dose is enough. One dose given after 1 year of age, live attenuated vaccine has got enough data for up to 17 years. Single dose is enough. Whereas for inactivated vaccine, you have to give 2 doses. 0 and 6 months. 6 months. The efficacy of both the vaccines is nearly equal. Long-term immunogenicity is fairly good. Okay?
Okay, sir.
My next question. Suppose a child gets IVIG for Kawasaki. What is the vaccine advice will you give? You treat a child with Kawasaki with IVIG. What is
Will
the
you repeat the
discharge?
question, sir? Because I couldn't hear properly.
Sorry, sir. Question
Yeah,
is,
just
with Kawasaki
repeat.
disease,
Yeah.
Kawasaki disease receives IVIG 2 gram per kg and is being discharged. What is the discharge vaccination advice will you give? Anybody can put in the chat box. Somebody has put delay for 8 to 12 months. Delay what? Delay DPT? Okay. The correct answer is high dose IVIG. You are not supposed to give MMR or varicella vaccine for about 11 months because IVIG will contain very high titers of antibodies against common exanthematous illnesses like measles and chickenpox. So it's not contraindicated. It won't be effective. It won't be effective. Okay.
Okay, sir.
In general, live vaccines are contraindicated in persons with immunodeficiency as a rule. For example, any immunodeficiency, you can't give a live viral vaccine. Anybody who's on high dose steroids, cyclophosphamide, you can't give live viral vaccine. Okay. Whereas inactivated vaccines, like for example, influenza, inactivated vaccine can be given in those with humoral immunodeficiency. They're not contraindicated, right? In fact, you must be even careful to vaccinate even the household of a child with severe combined immunodeficiency or T cell immunodeficiency, because you can't even give oral polio vaccine to a sibling of an infant who has got severe combined immunodeficiency. So you should be very careful to give contacts also, live viral vaccine. Okay, particularly vaccines like oral polio vaccine, right? Then some other question I wanted to, what is BCGosis? What is BCGosis? Anybody can put in the chat box? Disseminated BCG. That is, you can get, multiple lymph nodes with where you prove that there is BCG in those tissues. You can have.
You have reported a few cases and interferon deficiency.
Yeah.
No?
And the moment you get BCGosis, you should always think of a T cell defect or a chronic granulomatous disease or MSMD, Mendelian susceptibility to mycobacterial disease, such as gamma interferon defect or gamma interferon receptor defect. Okay. And BCG adenitis and BCG abscess, how do you treat? Anybody? How do you treat?
BCG adenitis is the normal reaction.
Masterly inactivity and watchful expectancy. If there is suppuration and abscess, if it is small, you leave it. If it is big, you drain. Repeated aspiration. Not even
Drain
draining.
also,
Repeated
the
aspiration.
needle has to be inserted from above.
ATT is not indicated. Excision is rarely required unless it is too big and mechanically causing problems. Masterly inactivity. No INH, no antibiotic. Okay. In fact, in the UK, they are stopping to give neonatal BCG vaccine, particularly to Asians and Africans, because of the fear of BCG causing BCGosis in immunodeficiency. Okay, they want to delay it by about 2 months, ensure that the baby is all right, and they want to do screening for immunodeficiency before giving BCG. So one of the things, future things that's going to happen. We may not be giving BCG in the newborn period, we may be delaying it. And the new development is taking place in BCG. The new development is BCG revaccination. Adult BCG vaccination is going to be introduced in India. And BCG vaccine has of late been found to be useful in adults who are having contact with cases of tuberculosis. So for contacts also, along with the INH or rifampicin prophylaxis, BCG revaccination is also being attempted as one of the therapeutic interventions. ICMR is going to start that very soon. Okay, right. Sir, any other comments, sir?
Not from me, because you are a Pandit, so whatever little I knew, I already told. So there's nothing more for me to add. Satish, you would like to?
Satish, you want to add anything?
It was a very nice, actually, all the exam-oriented questions, and we are also getting some new points to learn. I think very nice discussion today. And
Yeah.
first, for the icing on the cake, because most of the doubts, because mostly the people couldn't will get the rickets short case. Most of.
Almost everything is covered by Dr. Bala.
No.
Yes, sir.
It's a good presentation by the postgraduate. I must congratulate the good job done by him. Okay, very well done, very well presented.
Thank you, thank you, sir. Thank you.
Nivedita, you want to add anything? You want to add anything?
I think she's
Hello?
busy preparing for
Yeah.
going to States.
Yeah, somebody has put
No, sir. No,
TNPA.
sir. Thank you, sir.
Yeah, anything else you want to add? You had put some information, some I saw one of the, you had put
Yeah,
something.
correct answer was given.
Okay, okay. Okay, okay. If there is nothing else, we can hand over to Satish for his final comments.
Sir, I think everything is covered by the student. Even the live action is nicely covered. So we'll go for the. I think we'll wait for the next session now. Thank you. Good night, sir.
Okay, okay.
Thank you, sir.
Thank you.
Next
Thank
time,
you.
I think you should show some ASCII,
And
Dr. Bala.
first thing important is the presentation was good, and most important, the name was very catchy. So I think we should condense it on. We remember that.
Okay.
Okay. Thank you. Bye.
Thank you, sir.